Your heart rhythm is the way your heart beats. Conduction is how electrical impulses travel through your heart, which causes it to beat. Some conduction disorders can cause arrhythmias, or irregular heartbeats. An arrhythmia is an abnormal rhythm of the heart and is caused by problems with your heart's electrical system. The electrical impulses may happen too fast, too slowly, or erratically, causing the heart to beat too fast. There are two basic kinds of arrhythmias. Braddock Ardea is when the heart rate is too slow, less than 60 beats per minute. Tachycardia is when the heart rate is too fast, more than 100 beats per minute. The cardiac conduction system is a group of specialized cardiac muscle cells in the walls of the heart that send signals to the heart muscle, causing it to contract. The main components of the cardiac conduction system are the SA node, AV node, bundle of His, bundle branches, and Purkinje fibers. The SA node, anatomical pacemaker, starts the sequence by causing the atrial muscles to contract. From there, the signal travels to the AV node, through the bundle of His, down the bundle branches, and through the Purkinje fibers, causing the ventricles to contract. This signal creates an electrical current that can be seen on a graph called an electrocardiogram, EKG or ECG. Doctors use an EKG to monitor the cardiac conduction system's electrical activity in the heart. In cases of heart block, the electrical signals that progress from the heart's upper chambers, atria, to its lower chambers, ventricles, are impaired. When those signals don't transmit properly, the heart beats irregularly. First-degree heart block. A first-degree atrioventricular node block occurs when conduction through the AV node is slowed, thereby delaying the time it takes for the action potential to travel from the SA node through the AV node and to the ventricles. The condition may cause dizziness or lightheadedness, or it may cause no symptoms at all. First-degree heart block may not require specific treatment. Certain medications can cause first-degree heart block as a side effect. Digitalis. This medication is commonly used to slow down the heart rate. If it's taken in high dosages or for a long period, digitalis can cause first-degree heart block. Beta blockers. These drugs inhibit the part of the nervous system that speeds up the heart. This can have the side effect of delaying electrical conduction within the heart, which can cause first-degree heart block. Calcium channel blockers. Among their other effects, calcium channel blockers can slow down the conduction within the heart's AV node, resulting in first-degree heart block. First-degree AV block is indicated on the ECG by a prolonged PR interval. The PR interval is normally between 0.12 and 0.20 seconds. A PR interval consistently longer than 0.20 seconds, or greater than 5 small boxes, indicates a first-degree AV block. Second-degree heart block, which is also called Mobitz 1 or Wenke block, is a disease of the electrical conduction system of the heart in which the PR interval has progressive prolongation until finally the atrial impulse is completely blocked and does not produce a QRS electrical impulse. Once the P wave is blocked and no QRS is generated, the cycle begins again with the prolongation of the PR interval. One of the main identifying characteristics of second-degree AV block, type 1, is that the atrial rhythm will be regular. Second-degree heart block type 2 is usually caused by structural damage to the conduction system of the heart. Causes of the structural damage to the conduction system include the following: myocardial infarction that damages the conduction system, idiopathic fibrosis, cardiac surgery, infections and inflammatory conditions, hyperkalemia, autoimmune diseases affecting the heart. Second-degree AV block type 2 should be treated with immediate transcutaneous pacing or transvenous pacing, because there is risk that electrical impulses will not be able to reach the ventricles and produce ventricular contraction. Second-degree AV block type 2 is clinically significant because this rhythm can rapidly progress to complete heart block. Atropine may be attempted if immediate transcutaneous or transvenous pacing are not available. For second-degree block type 2, you will see non-conducted P waves. Electrical impulse conducts through the AV node, but complete conduction through the ventricles is blocked, thus no QRS. The main difference of second-degree Mobitz 2 with third-degree heart block will be a P wave with every QRS. In second-degree block type 2, may not always be a QRS complex with every P wave. The rate will usually be regular. Also, the PR interval will be regular. In third-degree block, there may not be a P wave with each QRS, and the PR interval will not be the same with each PQRS. Third-degree AV block is also called complete heart block. This type of dysrhythmia indicates complete absence of conduction between atria and ventricles. The atria and the ventricles are not communicating with one another. The atrial rate is always equal to, or faster than the ventricular rate in complete heart block. The block may occur at the level of the AV node, the bundle of His, or in the bundle branches. Remember that the rhythm strip reflects two separate processes that are taking place. The SA node continues to control the atria and typically fires at a rate of 60 to 80 beats per minute. Since the atria and the ventricles are not communicating, one of the two remaining backup intrinsic pacemakers will take over. Either the junction will pace the ventricles, rate 40 to 60 beats per minute, or the backup ventricular pacer will discharge, rate 20 to 40 beats per minute. On the ECG, you will see normal P waves marching regularly across the strip. The P to P intervals are regular. You will also see QRS complexes at regular intervals. The unique feature is that the P waves and the QRS complexes will not be talking to each other. There is no relationship between the P and the QRS waveforms. The PR interval will be totally inconsistent, and you may even see P waves superimposed in the middle of QRS complexes. There will be more P waves than QRS complexes, because the intrinsic rate of the sinus node is faster than either the junctional or ventricular rates. Bradycardia is a slower than normal heart rate. The hearts of adults at rest usually beat between 60 to 100 times a minute. If you have bradycardia, your heart beats fewer than 60 times a minute. Bradycardia can be a serious problem if the heart doesn't pump enough oxygen-rich blood to the body. If you have bradycardia, your brain and other organs might not get enough oxygen, possibly causing these symptoms: near fainting or fainting, dizziness or lightheadedness, fatigue, shortness of breath, chest pains, confusion or memory problems, easy easily tiring during physical activity. A resting heart rate slower than 60 beats a minute is normal for some people, particularly healthy young adults and trained athletes. For them, Braddock Ardea isn't considered a health problem. Ventricular tachycardia is a condition in which the lower chambers of the heart, ventricles, beat very quickly. Ventricular tachycardia occurs due to a problem with the heart's electrical impulses. The condition may develop as a complication of a heart attack or may occur in people with certain conditions, such as valvular heart disease. Symptoms include chest pain, fainting, dizziness, and shortness of breath. Treatment options include medication to slow the heart rate, surgery, and an implantable device. Ventricular tachycardia is a Y-complex tachycardia. It is a cardiac rhythm with a rate greater than 100 beats per minute and a QRS width greater than 120 milliseconds. Unfortunately, beyond this simple definition lies a complex differential diagnosis with prognoses ranging from utterly benign to potentially lethal, requiring treatment strategies ranging from medications to emergent non-sedated cardioversion and implantable cardioverter defibrillator implantation. Atrial fibrillation, also called Afib, is a quivering or irregular heartbeat, arrhythmia, that can lead to blood clots, stroke, heart failure and other heart-related complications. Normally, your heart contracts and relaxes to a regular beat. In atrial fibrillation, the upper chambers of the heart, the atria, beat irregularly, quiver, instead of beating effectively to move blood into the ventricles. If a clot breaks off, enters the bloodstream and lodges in an artery leading to the brain, a stroke results. About 15 to 20% of people who have strokes have this heart arrhythmia. This clot risk is why patients with this condition are put on blood thinners. ECG features of atrial fibrillation: irregular rhythm, no P waves, absence of an isoelectric baseline, variable ventricular rate. QRS complex is usually less than 120 milliseconds unless pre-existing bundle branch block, accessory pathway, or rate-related aberrant conduction. Fibrillatory waves may be present and can be either fine, amplitude less than 0.5 millimeters, or coarse, amplitude greater than 0.5 millimeters. Fibrillatory waves may mimic P waves leading to misdiagnosis. Ventricular fibrillation is a life-threatening heart rhythm that results in a rapid, inadequate heartbeat. It is a rapid, life-threatening heart rhythm starting in the bottom chambers of the heart. It can be triggered by a heart attack. Because the heart doesn't pump adequately during ventricular fibrillation, sustained V-Fib can cause low blood pressure, loss of consciousness, or death. Emergency treatment includes immediate defibrillation with an automated external defibrillator (AED) and cardiopulmonary resuscitation (CPR). Long-term therapy includes implantable defibrillators and medications to prevent recurrence. The origin of ventricular fibrillation is the ventricles. This rhythm does not come from the sinus node. One way to think of ventricular fibrillation is that there are numerous little chaotic electric circuits within the ventricles, each forming a random pacemaker. Ventricular fibrillation results in no QRS complexes. Therefore, there is no organized or coordinated electrical activity in the ventricle and as a result, no coordinated mechanical contraction, Therefore, there are no heartbeats and the result is cardiac arrest. Causes of V-Fib include ischemia, lack of oxygen changes the electrical properties of the heart. Infarction, produces scars and the region around the scar often have abnormal electrical properties. Heart failure, a strained heart will be electrically abnormal. Dilated cardiomyopathy, a stretched out heart will have some fibrosis and abnormal conduction. I hope you learned from my video. Press subscribe and share to support my channel. Press the bell button to be notified by my upcoming videos. Thank you.